All are indications for surgery in fracture clavicle except is the question. If at all they want to frame a tough question in fracture clavicle, this is the question. Many a times in exams like our INI-CET, they are focusing on what are the indications for surgery. Okay, this is from Campbell's point. Several times repeated area, you should be thorough. Okay, so choice A, all are indications for surgery except choice A, displacement more than 1 centimeter, fracture near AC joint, associated scapular neck fracture, bilateral clavicle fracture. 4 choices have been given. You see, we know 90% of fracture clavicle can be managed conservatively. Throughout the world, 100 cases of fracture clavicle is coming to you. 90 cases can be managed with conservative with your figure of 8 bandage that everyone knows. Only 10% needs surgery. What are the indications? If it is a bilateral clavicle fracture, it is a sure indication for surgery. You cannot put figure of 8. Number 2, associated scapular neck fracture. This is called floating shoulder. This is called floating shoulder. This is a sure indication for surgery. You cannot do conservative management. Fracture near acromioclavicular joint, that is lateral most end of the clavicle, is a sure indication for surgery, right? And you cannot apply figure of 8. Displacement more than 1 centimeter is the wrong choice. This is the exception. This is the answer. This is the right answer. This is wrong because displacement more than 2 centimeter is the indication, not 1 centimeter. Now, the indication for surgery. These are the indications thoroughly you should know. Number 1, displacement more than 2 centimeter. Number 2, open fracture or impending open. What is the meaning of impending open? Look at this diagram. If you look at this image, see, the displaced fracture is causing tenting of the skin. Here you see the tenting of the skin. This is called impending open. Whenever you see a fracture like this, don't go for figure of 8. You have to go for surgical fixation. Number 2. Number 3, whenever there is associated neurovascular bundle injury. See, we all know the most common brachial plexus is involved, that everyone knows. Among the brachial plexus, medial cord of brachial plexus is most commonly injured in the fracture clavicle. Medial cord has several nerves, and textbook very specifically says among medial cord so many nerves are there. Medial pectoral nerve, median root of median nerve, musculocutaneous nerve, it is ulnar nerve, medial then medial cutaneous nerve of arm, medial cutaneous nerve of forearm. You all know so many things are there in the medial cord. Among that, when you read very carefully for MCQ, it says ulnar nerve is very commonly involved. So injury, whenever there is an injury to neurovascular bundle, your axillary artery can get compressed. Immediately you have to open and fix it, otherwise it will go for permanent injury. Associated scapula fracture. Whenever there is associated scapula fracture, when you give figure of 8, it will hurt the patient more. So you cannot go for surgery. Non-union, wherever in orthopedics, non-union comes, non-union, the treatment of choice is open reduction internal fixation with cancellous bone grafting. So it's an indication, right? Fracture near acromioclavicular joint, bilateral clavicle fracture, and floating shoulder. What do you mean by exactly by floating shoulder? Fracture clavicle, when it is associated with scapular neck fracture, definitely you have to go for surgery. You cannot manage conservatively. So this you should know thoroughly. It's a sure area, a very important area for NEET PG, FMGE, your INI-CET, especially INI-CET. Okay, we'll move on to the next question. Okay, so to finish fracture clavicle, majority cases can be managed conservatively using figure of 8 bandage. 10% needs surgery. These 8 are the indications to do surgery in fracture clavicle. Okay, yes. We'll move on to the next question. Identify the image and give your diagnosis. Is this AC joint dislocation? Is this rib fracture? Is this anterior shoulder dislocation? Is this posterior shoulder dislocation? This is a classical X-ray of posterior shoulder dislocation. It is not acromioclavicular joint dislocation. This is the acromioclavicular joint. It is intact and the ribs seem to be all right. There is no rib fracture. If it is anterior shoulder dislocation, this head will be in front of the glenoid you cannot see the glenoid so clearly. I am able to see the glenoid very clearly. See the glenoid very clearly. I am able to see the glenoid, and I am seeing the head like a bulb. Head like a bulb. This is called light bulb sign, a classical X-ray sign of posterior shoulder dislocation. Posterior shoulder dislocation gives two X-ray sign, dear friends. One is called empty glenoid sign. All are asked questions, very important. Empty glenoid sign is otherwise called vacant glenoid sign. Okay, you see here, I am able to see the glenoid cavity fully and it is vacant. I will rub it, you just see. Okay, it is vacant glenoid sign. And the space between the glenoid rim, this is your glenoid rim. The space between the glenoid rim and humeral head is more than 6 millimeter. This is a radiological criteria. Okay, so this is called empty glenoid sign, other is called vacant glenoid sign. Coming to the light bulb sign, you are able to see the head. No, I am not able to see where is the GT, greater tuberosity. I am not able to see where is the lesser tuberosity, LT. So everything, it looks like a bulb, exactly like a 40 watts bulb, Philips bulb. It looks like a bulb. Okay, it's called light bulb sign. You know why. Just recollecting the clinical features. What is the attitude of upper limb in anterior shoulder dislocation, posterior shoulder dislocation, inferior shoulder dislocation? That will give you the answer for this. Anterior shoulder dislocation, the head is lying in front of the glenoid. That's called pre-glenoid. That's the most common type. Pre-glenoid. Head is lying in front of the glenoid. It's called pre-glenoid. That's the most common type. What happens? The arm, the affected upper limb is extended, abducted, externally rotated. Patient will come to you like this. This is the attitude of anterior shoulder dislocation. He cannot touch the opposite shoulder, and that is called Dugas test. I may be able to touch the opposite shoulder. Anteriorly dislocated patient cannot touch the opposite shoulder. That's called Dugas, because the arm is extended, abducted, externally rotated. Okay. So posterior shoulder dislocation, arm is adducted, internally rotated. The arm is adducted, internally rotated. Patient will support his affected limb like this, and he will come to the OP in this attitude. This internal rotation, this position is called sling position. This position is called like a sling, as if the upper limb is in a sling position. In this position, you cannot see when the head is internally rotated, the GT and LT, you cannot see. It will look like a rounded head like this, like a light bulb. So this is the reason for light bulb sign in posterior shoulder dislocation. Inferior shoulder dislocation is called luxatio erecta. Patient will come in hyperabducted upper limb like this, and this is called salute position. So salute position is the position for inferior shoulder dislocation. Sling position is the position for posterior shoulder dislocation. That is the cause for light bulb sign. Extended, abducted, externally rotated does not have any specific name. That is the attitude of anterior shoulder dislocation. Okay, so I think we are very clear. We'll move on to the third question. What is Holstein-Lewis fracture? See, we know Holstein-Lewis fracture is a type of fracture that happening in the shaft of humerus. In the shaft of humerus. Proximal 1/3, distal 2/3 junction with the entrapped radial nerve. Proximal 1/3, distal 2/3 junction without entrapped radial nerve. Proximal 2/3, distal 1/3 junction with entrapped radial nerve. Proximal 2/3 and distal 1/3 junction without entrapped radial nerve. 4 options are there. So you are becoming pundits in orthopedics. Okay, excellent. Proximal 2/3 with distal 1/3 junction with an already entrapped radial nerve is called Holstein-Lewis fracture. And you see this diagram. Holstein-Lewis fracture is an orthopedic emergency. Okay, it is an orthopedic emergency. It's an orthopedic emergency because see the area. It is an oblique fracture and it is there in the proximal 2/3 distal 1/3 junction. Here there is this yellow color structure is the entrapped radial nerve. So patient will present you with a wrist drop. Fracture shaft of humerus with a wrist drop. Holstein-Lewis. See why I am telling it's an orthopedic emergency. Most of the shaft of humerus fracture can be managed conservatively. Again, the book says most of the fractures can be managed conservatively. You know, humerus is padded by fleshy muscle. which has lot of blood supply. So it has a good tendency, when you immobilize, it has a great tendency to go for healing. So most of the fractures can be managed conservatively. But whenever you get Holstein-Lewis, already there's an entrapped radial nerve, immediately should open, decompress the nerve and fix it with a plate and screw. So whenever Holstein-Lewis fracture comes, the treatment of choice is emergency open reduction, decompression and internal fixation. Decompression of the nerve, internal fixation with plate and screw. So that I am using the word orthopedic emergency. In the topic humeral shaft fracture, the indication for surgery in humeral shaft fracture, the first indication is our Holstein-Lewis, and this is an expected question. What is Holstein-Lewis? What is the level of the fracture? Is an expected question. Shall we move on to the fourth question? All are X-rays of supracondylar fracture except. Look at the X-ray. X-ray A, X-ray B, X-ray D and X-ray C. Four things are seen. I am seeing a very classical sign here, that is called the teardrop sign, which is a sign of supracondylar fracture. I am able to see some gaseous shadow in the posterior aspect of the humerus and the anterior aspect of the humerus. And this is called fat pad sign, a beautiful sign of supracondylar fracture. I am able to see a crescent shaped opacity here, which again is a good sign of supracondylar fracture. All these are lateral views. In this anterior-posterior view, I am seeing a fracture only in the lateral condyle. I am not seeing any supracondylar fracture like this. I am not able to see any supracondylar fracture. Supracondylar fracture means it should go like this. But I am seeing in AP view a fracture involving only the lateral condyle. So all are X-rays of supracondylar fracture except A. The next slide I am going to explain all the X-ray findings of supracondylar fracture. You see one by one. Okay, first I am going to show you a normal elbow joint lateral view. This is a normal elbow joint. Okay, laterally this X-ray is a normal. When you see here, I am able to see this is the capitulum, the small thing, this one, that's the capitulum. This is your olecranon. This is your radial head. Okay, this is your radial head. I am able to see something like this. In the lateral view, I am able to see something, a shadow like this, and is it not looking like a teardrop? It's looking like you zoom your thing, you can see something like a teardrop. The first sign, no, there is breakage of this teardrop. You can see here, there is a breakage of this teardrop. So this is called teardrop sign on lateral view of the elbow is a normal X-ray sign in normal individuals. Whenever teardrop sign is broken, whenever there is a breach in the teardrop sign, that says it is supracondylar fracture. So this is called teardrop sign broken. That is a sign of supracondylar fracture. Number two, when you see here, supracondylar small fracture line is here, you are able to see a gaseous shadow in the posterior aspect of the humerus and in the anterior aspect of the humerus, and this is called fat pad sign. This is called fat pad sign. Fat pad sign. Okay, this is teardrop sign. Teardrop sign broken. That's the correct explanation. Broken teardrop sign. Okay, when you see the third sign, this is an AP view. This is the proximal fragment of the fracture. This separate piece is the distal fragment of the fracture. Okay, this big one is the proximal fragment. Okay, this big one is the proximal fragment. This small one is the distal fragment. When you see the proximal fragment, the end of the proximal fragment, the edges are serrated, and is it not looking like a fishtail? So this is called fishtail sign. This is called fishtail sign. The last one, okay, your doubt, okay. You first see the normal X-ray, man. You see here, this is the capitulum, this is your olecranon. Now when you zoom your app and see, you can see a very confident translucent space between the capitulum and the olecranon. That is normal. There is a gap between the capitulum and the olecranon, that is a normal one. When you see here, there is overlap of the capitulum into the olecranon giving a crescent-like opacity. You know crescent is referred to our moon, on the third day moon. Okay, so it's called crescent. Exactly, that looks like a crescent. Okay, so it is called a crescent sign. It's called crescent sign. This is nothing but overlapping of the capitulum over olecranon. Okay, you should see a space between, a gap between the capitulum and olecranon. That is normal. When capitulum goes and overlaps the olecranon, that will give a crescent sign, which is a sign of supracondylar fracture. I think I had cleared your doubt. Shall we move on to the next question? So, what are the 4 radiological signs of supracondylar fracture? Please focus your attention. One more extra MCQ I am going to tell now. Fat pad sign, teardrop sign broken, fishtail sign, crescent sign. 4 named signs of supracondylar fracture. They have asked all these questions. They can ask you one more question. Among the 4, which is more reliable? Among the 4, which is more reliable? The most reliable sign of supracondylar fracture, radiological sign, is the first one, fat pad sign. Because whether the fracture is complete or incomplete, whether it is displaced or not, sometimes even you cannot see a hairline fracture. But when you see fat pad, a gaseous shadow like this, you should consider that as a case of supracondylar fracture and should treat like supracondylar fracture. Okay, so even sometimes you may miss a hairline fracture, but when fat pad is present, it says some sort of breakage has happened in the supracondylar area. Okay, with this, we will move on to the 5th question. Best treatment for volar Barton fracture. Below elbow POP cast with palmar flexion and ulnar deviation, above elbow POP cast with wrist extension, open reduction internal fixation with T-buttress plating, K-wire fixation. 4 options I had given. The best treatment for volar Barton. See, all these are treatment for distal radial fractures. See, all the 4 are treatment of choices for distal radial fractures. What are the distal radial fractures that are possible in us? It can be Colles fracture. It can be a Smith fracture. It can be a volar Barton. It can be a dorsal Barton. It can be radial styloid. 5 fractures are possible in distal radius. Colles, reverse Colles, otherwise called Smith, volar Barton, otherwise called classical Barton, dorsal Barton, radial styloid. 5 fractures are possible. The best treatment for volar Barton is always open reduction internal fixation with T-buttress plating. T-buttress plating. This T-buttress plate, old books gives a name, Ellis plate. Okay, gives a name. This is called Ellis plate. Right. Now let us see one by one. Below elbow POP cast with palmar flexion and ulnar deviation is the best treatment for Colles fracture. Colles fracture. Best treatment for Colles fracture. You see, below elbow POP cast in palmar flexion, ulnar deviation. This is called Colles cast. This is called Colles cast. And when you see this like this, is it not looking like one machine? And that is called cotton loader. You just go to your net and see how a cotton loader exactly to look like this. So this position is called cotton loader's position. Cotton loader's position. Okay, immobilize. You are immobilizing Colles fracture. To treat a Colles fracture, you have to give traction, palmar flexion, ulnar deviation in full supination, because see, everything in Colles I cannot teach. When you go to the main video, 6 displacements of Colles I have mentioned. Dorsal tilt, dorsal displacement, lateral tilt, lateral displacement, impaction, supination. I had given a mnemonic for that, Dill's mnemonic. Dorsal tilt, dorsal displacement, impaction, lateral tilt, lateral displacement, then supination. When you want to neutralize these 6 components, one has to give traction. When you give traction, impaction is neutralized. When you go for palmar flexion, dorsal tilt and dorsal displacement is neutralized. When you shift it to ulnar deviation, radial tilt and radial deviation is neutralized. Then in full pronation, you are keeping the arm in pronation, the supination is neutralized. So this position of keeping a below elbow POP cast in pronation, palmar flexion, ulnar deviation, this is called cotton loaders position. That is called cotton loaders position. This cast is called Colles cast. This is the best treatment for Colles fracture. Okay. Number 2, above elbow POP cast. Okay. Above elbow POP cast with wrist extension is the best treatment for Smith fracture. Smith fracture. Smith fracture is the exact opposite to the Colles. Instead of dorsal tilt and dorsal displacement, you will get ventral tilt and ventral displacement. So Smith fracture. And open reduction with T buttress plating, exactly like this, is the best treatment for Olar-Barton. Olar-Barton fracture. The main difference between Barton and Colles is extra-articular, Barton is intra-articular. When the fracture line goes into the joint space, that is called Barton. When the fracture is exclusively extra-articular, not at all involving the joint space, then it should be Colles or Smith. Okay, so that is the difference. Whenever a fracture in orthopedics, involves a joint, intra-articular extension is there, the best treatment is open reduction internal fixation, because since it's involving the joint surface, perfect anatomical reduction is needed. When you just give a POP, it will heal, but it will malunite. Whenever the joint congruity is not maintained, your wrist will go for arthritis. That is why whenever a fracture involves a joint space, it needs surgery. So the best surgery for Olar-Barton is open reduction internal fixation with a T buttress plating. Olar-Barton T buttress plating. If the same thing, if it is dorsal Barton means the distal fragment is dorsally placed. So when you open on dorsal aspect, you will injure a lot of tendons. So the best management for dorsal Barton is closed reduction fixation with K-wire. This is also surgery. This is not POP, it's a surgery. Okay, so for dorsal Barton, this is the best treatment. Usually we won't put plate for dorsal Barton. So that we have completed the best management for distal radius. We will move on to the next MCQ. You see, Schaffer's fracture is. What is Schaffer's fracture? Intra-articular distal radial fracture, radial styloid fracture, intra-articular comminuted fracture base of the first metacarpal, intra-articular oblique fracture of base of the metacarpal. So easily you will answer yes. Okay, excellent. Schaffer's fracture is nothing but radial styloid fracture. Okay, radial styloid fracture. You see here, I will explain one by one. Bennett fracture is an oblique. You see here, this is the fracture line. Okay, I will erase, you zoom and see. Okay, here is the fracture. Oblique intra-articular fracture of the base of the first metacarpal thumb. Bennett. If there is a comminuted fracture, comminuted intra-articular fracture of base of the first metacarpal thumb, then it's called Rolando. There is a wrong teaching going on that if it is one is intra-articular, one is extra-articular. Bennett is intra-articular, Rolando that is wrong. Both are intra-articular. You should know Bennett and Rolando both are intra-articular, involving the joint, first carpo-metacarpal joint. If it is comminuted, it is called Rolando. If it is oblique, that's called Bennett. Okay, right? And if the fracture involves only the radial, you see here, only the radial styloid, a small portion like this. I will erase, you see, radial styloid. Here is the fracture line. Radial styloid. Then this is called Schaffer. This is called Schaffer. We all know Schaffer means driver. Olden days, before your ignition, that self-starter, you know, it was invented by Sir Henry Ford. Okay, Ford car company, Henry Ford. So they introduced the self-starter ignition key. Before that, no, every time when you want to start your car, you should have seen in old English pictures like Titanic. Okay, right? You see, olden days, you have to go in front of the car, put what is called a handle. It will be L shape, a handle, and the driver has to, the chauffeur has to start the car. Once the car engine has started, will give a backfire, it will come and hit the radial styloid. Repeatedly, they were getting the radial styloid fracture. So radial styloid fracture was historically called as chauffeur's fracture or backfire fracture. Originally, this fracture was demonstrated by our great Hutchinson, or Hutchinson's clinical medicine. So it's called Hutchinson's fracture. So what are the synonyms for radial styloid fracture? Hutchinson's fracture, backfire fracture, chauffeur's fracture. Okay, so finally Barton, as I told you, when there is distal radial fracture which goes inside the joint, when you see in the lateral view, you see it's going inside the joint, a volar one fragment is there, one volar aspect, a separate fragment is there. So this is the classical volar Barton or Barton's fracture. As I told you, right, the best treatment for Bennett is K-wire fixation. The best treatment for Rolando is mini screw fixation. Other two already I have explained. Okay, we will move on to the next question. Okay, yes, all of the following facts are true regarding fracture scaphoid except. See, I am covering all the fracture one by one in a very quick fashion because this is rapid revision. Important topics, we have to cover 40 topics, important topics. That's our idea. Okay, that's why everything in detail, very slow fashion, or like a slow motion picture, no, it's there in our main video. Okay, you see here, all of the following facts are true regarding fracture scaphoid except commonly happens in young adults. Most common site is waist of scaphoid. AVN, avascular necrosis, is a common complication in distal pole. Undisplaced fracture is treated by Bowler gauntlet cast. The right answer, yes, all of you have answered. Avascular necrosis is a common complication in distal pole is the wrong choice, except choice is that because it's common in the proximal pole. Okay, it's common in the proximal pole. Excellent, man, marvelous. Proximal pole, avascular necrosis, right? Now you see, just we will rush scaphoid fracture. It is the most common corporal bone to be fractured. Most common corporal, there are 8 corporal bones in human body. The most common corporal bone to get fractured is scaphoid. Most common age is young adults. Very rare in elderly, very rare in children. Two extremes of age, it's very rare because elderly and in children, distal radius, the distalmost portion of the radius is weaker than scaphoid. So fall on outstretched hand, first to go for fracture is distal radius, not scaphoid. In young individuals, young adults, distal radius is very stronger than scaphoid. So fall on outstretched hand, the most common fracture is scaphoid. Okay, that's the mechanism. Right, most common site that is involved 80% waist. Most common complication is avascular necrosis of the proximal pole of the scaphoid, which is called Preecier's disease. Expected question, Preecier's disease. Okay, it's called Preecier's. Avascular necrosis, everything, each and every area has a name. Okay, so proximal pole AVN of scaphoid is called Preecier. And most important clinical sign is pain and tenderness in the anatomical snuff box. When you press over here, when the patient has fullness, tenderness, severe pain, you are touching the scaphoid through this, not like this. You should palpate it through anatomical snuff box. Number 2, what is the classical deformity in a displaced scaphoid fracture? You see here, this imaging shows a fracture scaphoid which is displaced and it is looking something like this. The shape has become like this. Is it not looking like a humpback? So displaced scaphoid fracture, so far unasked in any of our Indian entrants, it is called humpback deformity. Humpback deformity. Displaced scaphoid fracture, the deformity is called humpback deformity. 2 important clinical signs of fracture scaphoid. One is called scaphoid lift test. Okay, you just catch hold of the hand, you shift the hand dorsally and ventrally like this. There will be severe pain that is experienced over the scaphoid. This is called scaphoid lift test. Another test is called Watson's test. Watson's test is very simple. Okay, ask the patient to keep the hand over a table supported like this. From the ulnar side, ask him to slowly move towards the radial deviation. From ulnar side, you ask the patient to put the hand over the table like this. Ask him to shift the hand from ulnar side to the radial side like this. Severe pain is experienced over the scaphoid. This is called Watson's test. So far unasked in any of the Indian entrance. Watson's test is positive in scaphoid fracture, okay, because Watson, very famous trauma surgeon, Watson Jones, okay, so Watson's test. Now imaging, we all know X-ray many times will cheat us. The best X-ray view is called, this is called scaphoid view. You have to put an oblique, in an oblique fashion, you should keep the hand like this and should pass the image. So it will give an exact image like this, and easily you can see a scaphoid. Scaphoid means boat shaped. That's why this bone is boat shaped. So that's called scaphoid. Okay, scaphoid means boat. Okay, boat. So that's why an abdomen which goes indrawn like this is called scaphoid abdomen, like a boat. Okay, so it's called boat shaped. You can see the X-ray scaphoid is seen like this. This is the best view. But many times, if there is a hairline crack, even a very good digital X-ray, you cannot see the fracture line clearly. Clinically, patient will have tenderness, pain, tenderness and fullness of the anatomical snuff box. Clinical sign will be positive. Radiologically, you are not able to prove. What will you do next? This question has been repeated 3 times in AIIMS exam. AIIMS is the old name for our INI-CET. So very high chance that this may get repeated again in INI-CET, NEET PG or FMGE again. You see here, whenever you are clinically strongly suspecting scaphoid fracture, radiologically not able to prove, what will you do next? This was the question. You just see your old question bank 3 times repeated. What you have to do, if clinically when you strongly suspect scaphoid fracture, treat that as a scaphoid fracture. Give a below elbow POP cast in glass holding position. Okay, I will show you. This is called Bowler gauntlet cast. In this position, you just give a POP cast, treat like a scaphoid. Over diagnosis is better than under diagnosis as far as scaphoid is concerned. You ask the patient to come after 3 weeks, repeat the X-ray, the same scaphoid view, oblique view. After 3 weeks, when it shows a healing fracture line, okay, because callus will start forming, so that may show a healing fracture line. Okay, an opaque line will be seen. When you see like that, continue the cast for 8 to 10 weeks. Continue the cast. Even after 3 weeks, X-ray is not showing any healing fracture line, remove the cast and leave him free. This is how you should manage a case of scaphoid fracture. Okay, and whenever they ask an MCQ, which is the best investigation, X-ray is not the best investigation, MRI is the best investigation. Okay, it detects much earlier and more precisely than X-ray. So MRI is the best investigation. If MRI best investigation for scaphoid fracture, the choice MRI is there, they are asking for that. Because the worst complication, the most troublesome complication, dangerous complication of scaphoid fracture is avascular necrosis of the proximal pole of scaphoid, and textbook says that, however, a good orthopedician, however, in a very good time you have treated properly, 40% is the chance of avascular necrosis of proximal pole of scaphoid. However good you treat a case. So that's the worst notorious complication. So over treatment is better than under treatment, and whenever possible do an MRI and confirm. Okay, yes. Coming to treatment, if it's an undisplaced scaphoid fracture, below elbow POP cast in tumbler holding position or glass holding position like this. This is called, this is a tumbler. Okay, the diagram, okay, maximum, it looks like a small lemon, but it's, you just imagine that's a glass. Okay, so like a glass holding position, this is the position. This is called Bowler gauntlet cast. This is called a Bowler gauntlet cast. Bowler gauntlet cast. This is the best treatment for undisplaced scaphoid fracture. If the scaphoid fracture is displaced, no, you have to go for Herbert screw fixation. Several times repeated MCQ, very important. You see here, one screw is placed. You see the peculiarity of the screw. The screw does not have a head. Here there is no head. Always whenever a screw means a head will be there, a shaft will be there, like this, a tip will be there, and threads will be there. This is how a screw looks. But here the head is absent. So Herbert screw is an headless screw because it is buried inside the scaphoid, that small bone, and you should not remove it back. Okay. So that is the treatment. Herbert screw fixation is the treatment of choice for displaced scaphoid fracture. That completes scaphoid fracture. We'll move on to the next question. Very much, many times repeated question of your INI-CET. Identify the image. Military anti-shock trousers, anterior external fixator, pelvic binder, pelvic C-clamp, image based. This is a repeat question. High chance the same question may come again. This is a classical image of pelvic C-clamp. This is the answer. Pelvic C-clamp. Okay. So this comes under the topic, how will you manage the retroperitoneal hemorrhage in pelvic fracture? Okay. We are seeing one by one all the fractures we are covering. Okay. You see here, pelvis fracture. Whenever a pelvis fracture happens, the life-threatening complication is retroperitoneal hemorrhage. Is retroperitoneal hemorrhage. Whenever you suspect retroperitoneal hemorrhage, it's a concealed hemorrhage. Outside you cannot see anything. The abdomen may start bloating, pulse rate, there will be tachycardia, hypotension. Patient may collapse. So whenever you suspect a retroperitoneal hemorrhage, immediately you want to stop. No, before shifting to the emergency department, on spot, if possible, if you have, you should wear that patient military anti-shock trousers, because in army this is available. Must. They will pump it with pressure so that venous return, everything is blocked and the bleeding is arrested. Must. This is the first thing. If you have this, that's the best thing. Otherwise, you just, before shifting it to the ambulance itself, on the spot, you just tie it with a pelvic binder. This is military. All these questions can be repeated, man, in image base. This is a must. Okay. Military anti-shock trouser. This is the pelvic binder. Once you just shifted the case to emergency department, there the resident will do an pelvic external fixator. That's called, you see, to the anterior superior spine. Okay. Through the iliac crest, I will just stabilize the pelvis, so that what is the cause for retroperitoneal hemorrhage? Venous, mainly venous. When the pelvis fracture has happened and it is moving, the fragments are moving, the bleeding is from the veins. Okay, the main thing is to stabilize the bone. Best stability can be get by your anterior external fixator. So this is possible only when the patient reaches the hospital or the emergency department. Anterior external fixator. This was the asked question. How they asked in INI-CET, a patient has sustained the severe pelvic fracture. What is the first thing you will do when you are received in emergency department? You are received in emergency department, pelvic binder or mast is not, you have to stabilize the bone with your external fixator. So this is the answer. Once you have done this, you are stabilized electively, instead of pelvic anterior external fixator, another thing which has come is pelvic C-clamp. This is also a type of clamp, external fixator, pelvic C-clamp. Okay, they have asked this question in INI-CET, so I have asked the next question for you, so that this may be your futuristic MCQ, pelvic C-clamp. Once you are done and stabilize the bone, electively you can go for open reduction internal fixation with the plate and screw. That's called internal fixation. This is the definitive management. If bleeding is not controlled by any of the above means, the final thing is, and you do an angiography with interventional radiologist, you just embolize, you block the vessels. This is the final treatment. So, how will you manage retroperitoneal hemorrhage in pelvic fracture? Mast, pelvic binders, anterior external fixators, pelvic C-clamp, internal fixation, final resort is angiography and embolization. With this, we will move on to the next question. A 27-year-old male was traveling by flight. The landing was little unexpectedly harsh. Okay, the flight landing was little unexpectedly harsh. When the flight was landed, he was not able to get up. His right lower limb went for an attitude of flexion, abduction, external rotation. Flexion, abduction and external rotation. What could be the probable diagnosis? Could it be fracture neck of femur, anterior dislocation hip, posterior dislocation hip, central dislocation hip? Okay, so what could be the answer? The right answer, by looking at attitude of his lower limb, this should be a case of anterior dislocation hip, right? So now let us rush dislocation hip. Three types of dislocations are possible in the hip. Posterior, the most common; anterior, the next common; central, the least common. The mechanism of injury of posterior dislocation hip is dashboard injury, car accident. You are not worn a seat belt, your flexed knee will go and okay, it will hit against the dashboard. So it's called dashboard injury. That's the most common mechanism. The mechanism according to textbook is for anterior dislocation hip is air crash, air crash landing. Okay, air crash, you cannot see anything, only ashes will be there. Crash landing. Okay, crash landing, right? And coming to the attitude of the limb, no, flexion, abduction, flexion, adduction, internal rotation. Flexion, adduction, internal rotation classically seen in posterior dislocation hip. So there will be shortening of the affected limb, and very classically there will be positive vascular sign of Norath. Expected question. What is vascular sign of Norath? Please listen. This is a concept based area. Please listen. Put the patient in supine position. Palpate the femoral artery pulse. Femoral artery pulse should be easily palpable because underlying the femoral artery there is a good bony structure. What is that bony structure? It can be a head of the femur or neck of the femur. Head is there or neck is there below your femoral artery. So whenever I press, underlying bony support is there, so I can be easily able to palpate the pulse. If the underlying bony support is lost, for example, fracture neck of femur or posterior dislocation of the hip, underlying bony support is lost. So whenever I try to palpate the femoral artery pulse is feeble or absent. You can't palpate. That is called a positive vascular sign of Norath. Whenever you get positive vascular sign of Norath, the differential diagnosis are kindly take down. Please, otherwise you will please listen. Okay, you see, whenever vascular sign of Norath question comes, positive vascular sign of Norath is seen in, the answers are, it can be posterior dislocation hip, it can be developmental dysplasia hip in a newborn, can be fracture neck of femur, it can be Tom Smith's arthritis, which is an osteomyelitis affecting head of the femur. Okay, totally it will eat away the head. Tom Smith's arthritis. Otherwise, tuberculosis of the hip, the final treatment is excision arthroplasty, which is called Girdlestone's excision arthroplasty. I repeat once again, vascular sign of Norath is positive in posterior dislocation hip, developmental dysplasia hip, fracture neck of femur, Tom Smith arthritis, Girdlestone's excision arthroplasty. Okay, very, very important. Other way, when you see the anterior dislocation hip, it is flexion, abduction, external rotation. So there will be limb lengthening. Okay, there will be limb lengthening. And the most common nerve that is affected in anterior dislocation hip is femoral nerve. Femoral nerve is compressed. Most common nerve that is affected in posterior dislocation hip is sciatic nerve. It is sciatic nerve. Ask the question, sciatic nerve. And vascular sign of Norath will be negative. It is not positive in case of anterior dislocation hip. Then what is central dislocation hip? Central dislocation hip means, you see, hip joint is a ball and socket type of joint. Socket is your acetabulum and ball is head of the femur. The head of the femur goes and it protrudes inside the socket. It will break the socket, it will go inside the socket. So head will enter the pelvic cavity. That is called central dislocation hip. So in central dislocation hip, you cannot see any abnormal attitude like flexion, abduction, external rotation, flexion, adduction, internal rotation. Nothing will be seen. The lower limb appears near normal. The attitude of central dislocation is near normal. But when you do perectal examination, you can palpate head of the femur in central dislocation hip. Okay. So what you look at the X-ray. In X-ray, I want all of you to know thoroughly what is Shenton's line. Okay, Shenton's line. Shenton's line is very much broken in any type of dislocation, posterior, anterior, or central, whatever it is. Hip dislocation, it is lost. What are all the differential diagnoses for vascular sign of Norath positive? No, they are the differential diagnosis for a broken Shenton's line in radiology and in ortho. Posterior dislocation hip, developmental dysplasia hip, fracture neck of femur, Tom Smith's arthritis, Girdlestone's excision arthroplasty. All are differential diagnosis. The same vascular sign of Norath, the DDs are the DDs for broken Shenton's line. What is a Shenton's line? Please, I know that you know that. This is a rapid revision, so I am revising for you. You see, this is the superior pubic rami. So the inferior border of the superior pubic rami, when you draw as a smooth line, it comes and curves the femoral neck. This is called Shenton's line. This is a case of posterior dislocation hip. This is a case of posterior dislocation hip. This is superior pubic rami. This is the inferior border. I am trying to draw a line. See, the line is broken because neck is here. Line is broken. This is the classical X-ray of anterior dislocation of the hip. This is the superior. This is the inferior border of superior pubic rami. See, the line is broken. Okay, your neck is here. This is a central dislocation. I told you, no, this is you see, this is normal acetabulum. You see the acetabulum is broken and head is entering your pelvic cavity. You see, zoom and see. Very, very classical. When you try to draw a Shenton's line, the line is broken. Line is broken. Okay. So this is about the classical X-rays of posterior hip dislocation, anterior hip dislocation, central dislocation of hip. Now, we will move on to the 10th question. Identify the fracture and find out the classification it fits. So, there is no doubt this is a case of fracture neck of femur. There is no doubt. My question is, what Gordon's classification this X-ray fit? Okay, what Gordon's classification? See, you see, this is an intact neck. Here there is a neck is broken. The fracture is complete and it is partially displaced. The fracture is complete and it is partially displaced. It should be Gordon's type 3. Marvelous, man. Let us quickly, because in fracture neck of femur, please listen, only 2 points are important. Number 1, Gordon's classification. Only when you know Gordon's classification and age of the patient, you can treat the case. If you don't know the Gordon's classification, you don't know the age of the patient, you cannot plan for management. Okay, so I'm going to quickly rush in another 2 minutes. We are going to see what is Gordon's and what is the best treatment for each type. You see here, type 1, the fracture is incomplete. Normal alignment trabeculae between the acetabulum head and neck. Trabecular pattern. You see here, Gordon's type 1. Fracture is incomplete. Type 2, fracture is complete but undisplaced. Absolutely no displacement. Here the trabecular pattern is well maintained. Type 3, fracture is complete, there is partial displacement. The trabecular pattern, you see, this is the trabecular pattern. This is very clean. Here it is altered. Trabecular pattern is altered. Okay. Then type 4, fracture is complete and totally displaced. This is type 4. Okay. Once you know this Gordon's classification, you go to the treatment of choice according to Gordon's classification and age of the individual. See, you just have all these things. This is in your slide. You focus your attention on my verbal teaching. Okay, I'll make it so simple for you. If fracture neck of femur usually won't happen in a child. If it happens in a child, treatment of choice is essentially conservative. That is, I won't do any major, I cannot do any joint replacement or anything in a child. Before skeletal maturity, joint replacement is contraindicated. You cannot do. So what I will do, I will immobilize the hip in a hip spica. Otherwise, I can fix it with a small screw called novel screw or a small pin called Moore's pin, named after the great Austin Moore. So Moore's pin or novel screw or hip spica if there is a fracture in a child. If it is Gordon's type 1 in an adult also, Gordon's type 1 is fracture is incomplete. So the bone has not broken completely. When I give 45 days rest, that will heal. So immobilization and hip spica, or I can put a small screw and I will wait. Nothing. If it is Gordon's type 2, that is fracture is complete but undisplaced. Fracture is complete but it's undisplaced. If it is a child, again the same treatment, hip spica, Moore's pin or novel screw. Okay. And if it is a young adult, for example, he is a 30-year-old individual, 25-year-old, 30-year-old individual, Gordon's type 2, that is fracture is complete undisplaced, I will fix it with 3-point fixation. Next slide, I will show you what is that. Now itself I will show you. You see here. See, it is complete but undisplaced. I had fixed it with 3 screws. In this angle, it looks like this. In this angle, when I look on end-on view, the 3 screws are fixed like this. Is it not looking like an inverted triangle? So this is also, it's looking like an inverted triangle. Okay. So this is called 3-point fixation. Golden treatment. Excellent treatment. for Gordon's type 2 in an young adult or even in an elderly. Even in an elderly, because you are not throwing away the head, you are preserving the original head. There is a high chance, because fracture is complete but undisplaced. When you fix it with 3 screws tightly, high chance blood supply, everything get re-established and the head will survive. So this is called 3-point fixation. Alternate to 3-point fixation for Gordon's type 2 in an young adult or in an elderly is called dynamic hip screw, DHS. You know pretty well, dynamic hip screw is a gold standard treatment for intertrochanteric fracture, but this can also be used for fracture neck of femur if it is Gordon's type 2. Gordon's type 1 or type 2, ideally for type 2 in an young adult or in elderly. This is called dynamic hip screw. So this is for this treatment. If it is Gordon's type 3 or type 4, type 3 means the fracture is complete and partially displaced. Type 4 means it is totally displaced. So in type 3 and type 4, guaranteed the blood supply is lost, because we know the notorious complication of fracture neck of femur is avascular necrosis and non-union. Okay, avascular necrosis and non-union. You see here the 3 main complications. First thing, this I had referred Campbell, I had referred Rockwood Green, these 2 Bibles of orthopedics, and I given the answer. Avascular necrosis 15 to 40%, non-union 15 to 36%. So in your MCQ, if they ask the most common complication of fracture neck of femur, should go only for this. This is the second common complication. No undergraduate book gives a clear definition like this. They will use the word avian and non-union. But MCQ, they are asking which is the most common. Avascular necrosis is the most common. Non-union 4% lesser. Whenever it goes for avian, it will go for non-union also. Okay. So see, this is, so whenever there is Gordon's type 3 or type 4, there is the fracture is complete partially displaced, a fracture is totally displaced, guaranteed blood supply to head of femur is lost, and definitely this will go for avian or non-union. So there you have to plan for replacement arthroplasty. Replacement arthroplasty. Replacement arthroplasty means I can replace the head and neck. I can leave the original acetabulum. This is called hemiarthroplasty. If I replace head, neck and acetabulum, that is called total hip replacement. That is called total hip replacement. So again in type 3 and type 4, again whether to go for hemiarthroplasty or total hip replacement depends upon the status of the acetabulum. If acetabulum is fine, it is not at all damaged, it is excellent, go for hemiarthroplasty. If acetabulum is also damaged, you have to go for total hip replacement. Okay, this is the treatment protocol. Okay, I had made it so simple for you. And the hemiarthroplasty, image based, you can expect 2. This is called the classical Austin Moore's prosthesis. This is called Thompson's prosthesis. Easy way of identifying. Here you are able to see 2 holes. You should not use the word holes, they are called fenestrations. They are called fenestrations. If the stem is fenestrated, that is Austin Moore. If the stem is non-fenestrated, that should be Thompson. Okay, you just have this. So let us revise the treatment protocol once again in fracture neck of femur. In a child, I won't do any surgery. Maximum I can fix it with a novel screw or Moore's pin. I will try to manage with hip spica. If it is an young adult or an elderly, for example, a 60-year-old above 60 years, or if it is if he is 30 years or 25, I will see what Gordon's. If it is Gordon's type 2, I will go for 3-point fixation, otherwise dynamic hip screw. If it is Gordon's type 3, type 4, I have to go for some replacement. Then I will assess status of the acetabulum. If acetabulum is fine, I will go for hemiarthroplasty. If the acetabulum is also damaged, I will straight away go for total hip replacement. Okay? Fine. We will move on to the next MCQ. The image shows method of taking a particular view. I am taking some view. I had made the patient lie down in a prone position. I am able to, I had flexed the knee joint. This is 45-degree flexion. I am taking an X-ray. I had kept the cassette here. Film is kept here. And I am passing the beam from outside like this. What is this view called? 45-degree flexion. This view is called axial view. This view is called axial view. When I had flexed it to the X-ray, you can see like this. You're able to see a fracture here in the patella. Okay. If I flexed it to 110, I am having the image with me. You just see the explanation. Now it will be very clear to you. Hey, yes, please register this in your mind. Highly expected question. You see, first I am going to explain this view. Here I had flexed my knee joint only to 45 degree. This view is called axial view, otherwise called skyline view, otherwise called merchant view. You will get an X-ray like this. Here, the knee joint here is flexed only to 45 degree. Here, the knee joint is flexed to 110 degree. You see, the lower pole of patella is in contact almost with the femoral condyle. You see here, femoral condyle, whereas here it is gone up like a rising sun. So this is called sunrise view. That's the only difference, man. Okay. So yes, Ruby has given a thumbs up sign. Yes. Okay. So 45 degree flexion is called axial view, otherwise called merchant view, the person who demonstrated, otherwise called skyline view. If you flex it to 110 degree, that's called sunrise view. Both are very good views to look for patellar fracture. Okay, we will move on to the next question. Yes, you see here, this is very important. In tibial condyle fracture, the most confusing thing is Schatzker's classification. Highly expected question in exams like INI-CET or NEET PG, highly expected question. In Schatzker-Tiles classification of tibial condyle fracture, type 3 corresponds to lateral plateau pure depression, medial plateau, lateral plateau split fracture, lateral plateau split depression. It is type 3 corresponds to lateral plateau pure depression. This is the right answer. Now let us rush through the Schatzker-Tiles classification. There are 6 types, type 1, 2, 3, 4, 5, 6. Type 1, lateral plateau split. Look at the image, lateral plateau split, very excellently with animations. I had explained in our main video. In all our main video, many animations are there. You cannot forget the visual memory. That is lateral plateau split. Type 2 is lateral plateau split depression. Type 3 is lateral plateau pure depression. Type 4 is medial plateau. Type 5 is bicondylar. Type 6 is plateau fracture with separation of metaphysis from diaphysis. Complete separation of metaphysis from diaphysis. Okay. These are the Schatzker-Tiles. This is the most important confusing area in tibial condyle, and one should not, I will tell a very important, again an MCQ point. The most dangerous or most important complication of tibial condyle fracture is compartment syndrome. Increased compartmental pressure of the leg. Okay, so one should be very careful. Always, whenever you come across a case of tibial condyle fracture, look for blisters in the skin. If you see blisters in the skin, that's the earliest sign to say that this patient is going for compartment syndrome. Emergency fasciotomy has to be done, otherwise you will lose the limb. Okay, tibial condyle fracture, another important thing, the main treatment is open reduction internal fixation, tibial condyle or plate. Open reduction internal fixation, plate fixation, that is the treatment of choice. The precaution you should take, whenever there is swelling, you should not operate. You should wait for a week or 10 with limb elevation. Around the tibial condyle, you should get what is called a wrinkle sign. In the skin, you should see some wrinkles. Whenever you see wrinkles around the skin in tibial condyle fracture, it's a good sign. Then only should operate. When the skin is very tense, when you put a knife and you operate, the wound won't heal. Notoriously, the wound will fail to heal. Okay, so the most important or most dangerous complication of tibial condyle fracture is compartment syndrome. Okay, we'll move on to the next question. A 30-year-old male has fracture involving distal tibia at its articulation with talus. Articulation with talus. Distal most portion of tibia in articulation is the talus, talotibial plane. The 30-year-old male has a fracture. What is the name of this fracture? Is it POTS? Is it cotton? Is it Masonovi? Is it tibial pylon? Because now we are going to discuss fractures around the ankle. Okay, 4 named fractures, often repeated area. It is tibial pylon fracture. The lowermost portion of tibia, when it get compressed, the talus, this is an example of impacted fracture. This is an example of impacted fracture. Impacted fracture means fracture neck of femur and tibial pylon, impacted fracture. Now let us see very quickly what is POT. What is POT? When there is a fracture of the medial malleoli, in the fracture of the lateral malleoli, it is called bimalleolar fracture, that is called POTS fracture. Okay. Mechanism of injury, this you have to memorize. Supination adduction injury or pronation abduction injury. Very important. Next is called cotton fracture. Next is called cotton fracture. That's called trimalleolar fracture. Cotton fracture is trimalleolar. Here you see the medial malleoli, the lateral malleoli and the posterior malleoli. 3 malleoli got fractured. That is called a cotton fracture. That is trimalleolar fracture is called cotton's fracture. When it is, you see here, when the fracture of the proximal third of fibula, with injury to the distal tibio-fibular syndesmosis or deltoid ligament, with or without medial malleolar fracture, that is called Masonovi. Not asked many times, highly expected one. And tibial pylon fracture is also known as tibial plafond fracture. It is fracture involving distal tibia articulation the talus. Usually this happens jumping from a height. Fall from height, landing directly on the feet. Calcaneum fracture can happen, tibial pylon can happen. It is caused by high energy axial load. Treatment of choice, since it is involving the intra-articular area, it cannot be managed conservatively with your POP. You have to go for fixation. Yes. Now, next thing, a very tricky question. I hope you guys will easily manage. Okay, easily you will manage. A 25-year-old male developed an aviatus fracture. Okay, aviatus fracture is name of the fracture. Okay, you know what fracture it is. Okay, on 1 month later, X-ray shows the following sign. What does this sign denote? A good prognostic indicator, a bad prognostic indicator, non-union, malunion. It is a good prognostic indicator. It's a good prognostic indicator. Aviatus fracture is nothing but fracture neck of talus. Fracture neck of talus is called aviatus fracture because this historically this happens in crash landing. Your pilots will sit, the aviator will sit and he will keep his foot in the rudder bar. What happens? No, that rudder bar, it causes injury and neck of talus will go for fracture. So historically this was called aviatus fracture. Nowadays this is very common in road traffic accident. Okay, but historically this is called, and it's a good sign. Why I said no, when you zoom your app and when you see this thing, this is the lowermost portion of the tibia. This is the talus. Near this articulating surface, only when I rub you can see zoom, you can see a translucent line in the subchondral area. Subarticular area, the arrows I had given, this is that line, a translucent line like a rope. I will rub you, just now you zoom and see. This is called Hawkins sign. A translucent area in the subchondral area is called the Hawkins sign. Whenever you see Hawkins sign after a month of talus fracture, it says that bone is live. Bone resorption is happening means metabolically the bone is active, which means bone is live. Talus is not dead. So it says that avascular necrosis has not happened in the talus. Like your scaphoid, the notorious complication of talar neck fracture is avascular necrosis of the talus. There it is called Hawkins disease. Avascular necrosis of proximal pole of scaphoid is called Precious disease. Avascular necrosis of the talus is called Hawkins disease. When you see a translucent zone in the subchondral area, that is called Hawkins sign. Hawkins sign says that AVN has not happened. So it is a good sign. You see, in type 1, type 2, the chance of AVN is 0 to 50%. Type 3, type 4, what are the 4 types I had given in our main recording? Just see the Hawkins classification I had given. Type 3 and type 4, the chance of AVN is 50 to 100%, man. 100%, 50 to 100% is the chance of AVN. So after 1 month, when you see Hawkins sign, it says the bone is live. And it's unlikely this bone will develop AVN. So it's a good prognostic indicator. Okay. So wherever, I used to teach my undergraduate students like this. Wherever you come across the word Hawkins in orthopedic MCQ, that question is about talus. The fracture angle is called Hawkins angle. The classification of talar fracture is called Hawkins classification. A good prognostic indicator is Hawkins sign. Avascular necrosis of talus is called Hawkins disease. Okay, wherever a word Hawkins comes in ortho MCQ, that question is something about talus. Okay, easy way to remember. Now, you identify the fracture. So this is a fracture of metatarsal. I am able to see a fracture of the 5th metatarsal. Is it Jones? Is it pseudo Jones? Is it March? Or is it Lisfranc? So the right answer is pseudo Jones fracture. The right answer is pseudo Jones fracture. See, this is the most confusing thing. When you should know it, when you should call it as Jones, when you should call that as pseudo Jones. Okay, I'll make it so simple for you. You see, the 5th metatarsal is divided into 3 zones. Zone 1 is up to this. Zone 2 is up to this. Zone 3 is up to this. Zone 1, from the tip 1.5 the centimeter is called zone 1. Anything above 1.5 is called zone 2. Okay, you see the fracture. When the fracture, I am able to see a fracture line here. I am able to see a fracture line here. I will erase, you see that. Okay, this fracture is very close to the articulating surface. This is called pseudo Jones. When it is away from the articulating surface, more than 1.5 centimeter is happening here. This is called Jones. And you should know one thing, pseudo Jones is otherwise called dancer's fracture. Again, few apps and few books are giving a wrong answer. I don't want to tell the wrong answer. This is the correct answer. Pseudo Jones was previously called dancer's fracture because this was happening very commonly in ballet dancers. Pseudo Jones. Okay. So this is Jones, that is Jones, this is pseudo Jones. Other is called dancer. March fracture is happening in the 2nd metatarsal. Neck of the 2nd metatarsal. This is called March fracture. March fracture is otherwise called stress fracture. Other is called fatigue fracture. Because this happens in army personnel or military recruits, those who do march fast for a long time, this happens, March fracture. Okay. So March fracture is neck of 2nd metatarsal. Pseudo Jones is from the tip within 1.5 centimeter of the articulating surface. Jones is more than 1.5 centimeter from the articulating surface. Okay. So this is Jones, this is pseudo Jones. One should be very clear. Now, what is the best management for a child with CTEV of age 3 months to 1 year? Congenital talipes equinovarus. The most important thing is congenital talipes equinovarus. The most important thing is age-wise treatment plan. Age-wise treatment plan. Okay. What will you do at birth? And my question here, first we will see the answer, then I will go for age-wise treatment plan. Most important area, CTEV. Okay. So 3 months to 1 year, what will you do? 3 months to 1 year, the best management is Ponseti's method. Ponseti's method. Now quickly we will rush through age-wise treatment plan. Treatment should begin as soon as birth. Immediately, the very first hour after birth you are diagnosed, you start treating, because the book says and the experience says that when you start the treatment early, prognosis outcome is very good. Okay, so birth to 30 days, from birth to 30 days, manipulation by mother. She dorsiflexes and invert the foot, maintain it for 5 seconds, repeat it after every 5 minutes. Do in the 24 hours as many times as possible. What the mother does, she dorsiflexes and everts the foot, and dorsiflexion, eversion of the foot. Okay, dorsiflexion and eversion of the foot. Keep it in that for 5 seconds. Repeat it every 5 minutes. Repeat it every 5 minutes. Okay, and repeat it for as many times as possible in 24 hours. Okay, whenever the child sleeps, no, mother should manipulate. Okay, it gives a very good result. 3 months has crossed. The CTEV has not resolved. The CTEV has not resolved. 3 months to 1 year. The best method is Ponseti's method or Kite's method. This is serial correction and casting. Look at the image. Seriously, this is a CTEV foot. Slowly corrected. Finally, you are getting a very straight foot. This is called serial correction. First, it was introduced by the great Kite. So it's called Kite's method. Later, slightly modified by the great Ponseti. And Ponseti method is the gold standard treatment for any CTEV between 3 months to 1 year. What is a serial correction? The order of correction is very important. Please listen. In Kite's method, first thing that is corrected is forefoot adduction. Next thing is inversion. Last thing is equinus. You know what? There are 4 deformities that are happening in congenital talipes equinovarus. Cavus of the midfoot, adduction of the forefoot, equinus at the ankle, inversion of the subtalar joint. Inversion of the subtalar joint. These are the 4 major deformities that are happening in CTEV. Okay. Kite, what he did, he corrected the forefoot adduction first, inversion next, equinus last. This order should not be reversed. When you change the order, CTEV will end up in a complication called rocker bottom foot. Rocker bottom foot. A worst complication of wrong correction of CTEV. This is the Kite's method. In Ponseti, one small alteration. First thing he corrected was cavus. Other 3 things in the same order. Kite corrected forefoot adduction first, inversion next, equinus last. Okay, Ponseti did cavus correction first, forefoot adduction next, inversion third, equinus last. This is called Ponseti. This is the gold standard treatment between 3 months to 1 year. 1 year to 5 years. 1 year to 5 years. You cannot go for conservative method. You have to go for surgery, and that is called turquoise procedure. Turquoise procedure is nothing but posteromedial soft tissue release, PMSTR. Posteromedial structures are released like your tibialis posterior, tendo Achilles, capsule of the ankle. All these things are released, and this is called turquoise procedure. Turquoise procedure, and other is called posteromedial soft tissue release. 5 years to 10 years, you cannot go for soft tissue release. You have to go for what is called a bony reshaping. When you reshape the talus, it is called Dwyer's osteotomy. When you reshape the talus, it is Dwyer's osteotomy. When you reshape the calcaneum, it is called Dillwyn-Evans procedure, bony reshaping. There is, once a baby has crossed 5 years, you have to go for bony reshaping. You cannot do the soft tissue release. Okay, yes, because you know the basic defect of congenital talipes equinovarus is congenital, that is primary germplasm defect of the talus. So the talus is not formed fully, faulty formation of the talus. So the child is going for intrauterine talonavicular dislocation. That is a basic pathology. That is the latest theory. Okay, so 5 years has crossed and you are not able to correct CTEV. You have to go for either reshaping of the talus, that is called Dwyer's osteotomy, or reshape the calcaneum, that is called Dillwyn-Evans procedure. Once the child has crossed 10 years and above, this age is very important, man, because they will give you 15-year-old child is coming in CTEV best management. Okay, once the child has crossed 10 years, the only treatment that is available is triple orthodesis. You cannot do anything. You have to fuse 3 joints. The 3 joints that are fused are talonavicular joint, calcaneocuboid joint, and subtalar joint. Okay, so it is talonavicular, calcaneocuboid, and subtalar. These 3 joints are fused. This is called triple orthodesis. When you fuse the joint mobility won't be there. Joint mobility won't be there. Why then you are fusing? You are giving a pain-free stable joint. You are giving a pain-free stable joint. So let us recollect. Immediately, it should be started treated immediately after birth, as soon as birth. So, immediately from day 1 of birth till 30 days, manipulation by mother. 2 months to 1 year, Ponseti's method. 1 year to 5 years, Turcos procedure. 5 years to 10 years, Dwyer's osteotomy or Dillwyn-Evans procedure. More than 10 years, triple orthodesis. That completes CTEV management. We'll move on to the next important chapter, DDH. All of the following facts regarding DDH are true except it is uncommon in India. Girl-boy ratio is 7:1. Left hip more than right hip. Incidence 3.5 per 1000 live births. Incidence is 3.5 per 1000 live births. Okay. So this is a fact-based question. So incidence 3.5 per 1000 live births is the wrong choice. Except is this. Okay. So the answer should be 1.5 per 1000 live births. So let us see. It is uncommon in India, very common in Europe, because you know the way we carry our child. We used to carry our child the hip like this. So most of the developmental dysplasia hip gets reduced spontaneously. European people won't carry their child like this. So very common in Europe. Girl-boy ratio from Apley, latest Apley 7:1. Mostly unilateral for unknown reason. Left hip is more commonly affected than right hip. All these are facts you should memorize. What is the basic defect which I taught you in case of congenital talipes equinovarus is primary germplasm defect of the talus. So it is going for faulty formation of talus and congenital talonavicular dislocation. This is what we had seen. The basic defect in case of developmental dysplasia hip is there is delay in ossification of the capital femoral epiphysis. This results in two deformity: small shaped head of femur, small and shallow acetabulum. So it is going for dislocated hip. Okay, these are the latest concepts from Apley. Okay, and the incidence is 1.5 per 1000 live births. 1.5 per 1000 live births. And this is the very important question. What are the predisposing factors? Okay, what are the predisposing factors? Vamshi had given one is from the previous edition. Latest you should know 1.5 per 1000. Okay, that's the right answer. And risk factors, no, breech presentation, number 1. Okay, what are the risk factors or predisposing factors for congenital dislocation hip, developmental dysplasia hip? Breech presentation. Number 2, firstborn child. Number 3, female child. Number 4, positive family history. Okay, the first cousins they are having. Then full term baby. So DDH is more common in full term than preterm because there is one thing called relaxin hypothesis. Relaxin is a maternal hormone that is secreted during parturition only when they attain full term. The very purpose of relaxin is to relax the pelvic ligament so that parturition becomes easier. That relaxin, for unknown reason, it is affecting the ligament of the hip joint and causing developmental dysplasia hip. That's called relaxin hypothesis, full term. Fetal package anomaly, several times repeated question, oligohydramnios. So they are given several times, in the exception they are given polyhydramnios, oligohydramnios. In foot anomaly, associated thing is metatarsus adductus. So you should never forget the 7, okay. Sir, in Q bank explanation, Ponseti. Yeah, Sahil Yadav, I will come to this little later. Okay, so it is, okay, so Q bank, there is some discrepancy. This is the correct thing. Okay, this is the correct thing. You please follow this. That's why I'm doing a rapid revision. Okay, this is the correct thing. Right. Foot anomaly, metatarsus adductus. So 7 risk factors, several times repeated question of NEET. What are the risk factors of DDH or predisposing factors for DDH? One should not forget. Yes. Then coming to clinical feature, in a newborn, very gross thing is limitation of abduction. The hip joint abduction is very much limited. Limitation of hip abduction. Very, very important. The earliest sign that says that the child may have a DDH. On examination, there is asymmetrical gluteal fold and thigh fold. Okay, gluteal fold and thigh fold. There will be shortening of the leg or additional crease on the posteromedial aspect of the thigh. Okay, you see here, Asymmetry of the gluteal, one gluteal fold is here, another gluteal fold is here. Okay, so asymmetry of the gluteal fold. And one should not forget the classical orthogonal test, Barlow's test, telescopic test, other is called piston test, Galeazzi sign, other is called Alice sign. One should not forget. So now I will explain one by one. Please focus your attention. Orthogonal test is called test of entry. Barlow's test is called test of exit. So what is that orthogonal test? Test of entry. For remembrance sake, we used to teach like that. Orthogonal is called test of entry. Barlow is called test of exit. See, you are receiving a baby. You are receiving a baby, and the baby already has a dislocated hip. Already the baby has a dislocated hip. Slow abduction and internal rotation. Slow abduction of the hip and internal rotation of the hip. With a click sound, head will get reduced inside the acetabulum. So you are getting a baby, and the baby is having an already dislocated hip. You are relocating the hip. You are relocating a dislocated hip. So the head is entering the acetabulum with a click. That is called orthogonal test. That's called orthogonal test. Barlow's test is, you are receiving a baby, the baby head is very much inside the acetabulum, you are suspecting DDH. So you are trying to dislocate a dislocatable hip. That word is very important. It's not dislocating a hip, dislocating a dislocatable hip. So it's a provocative test, no? So practically we won't do. So head is coming out, so it's called test of exit. We won't do practically, it's theoretical. Telescopic test or piston sign is very simple. The hip is dislocated. Flex the hip joint to 90 degree, flex the knee joint to 90 degree, push it down, pull it up, push it down, pull it up. Like a telescope it will go because the head is out of the socket. So it's called piston sign, other is called telescopic test. Piston sign, other is called telescopic test. Okay. So this is common. This telescopic test or piston sign can happen in posterior dislocation hip also, in fracture neck of femur also. So telescopic test is non-specific one. Alice test or Galeazzi sign, make the baby lie down like this in a supine position, flex both the hip to 90 degree, flex both the knee joint to 90 degree, both the knee joint should be at the same level. This is normal. If there is DDH on the affected side, knee joint will be at the, see the knee joint is here, one knee joint is here. So the affected side knee joint will be at lower level. This is called Galeazzi sign. Otherwise, this is called Alice test. The gait of DDH, no? When you ask the patient if it's unilateral DDH, they will walk with what is called a Trendelenburg gait. Asked question. The classical gait of unilateral DDH is Trendelenburg gait. The gait of bilateral DDH is called sailor's gait, other is called duck waddling gait. Okay. So these are the clinical features of developmental dysplasia hip. Okay. Yes. Now we will move on to the next question. Okay. All are associated with congenital torticollis except. All are associated with congenital torticollis except. Okay. So congenital talipes equinovarus, congenital dislocation of hip, Down syndrome, cerebral palsy. All are associations of congenital torticollis except. The right answer is cerebral palsy. Exception is cerebral palsy. Okay. Right. Let us quickly see what are the associations of, because congenital torticollis associations so far they have not asked, but it is there in all our standard books. This may be the futuristic question in ortho from pediatric orthopedics. Otherwise, may get in pediatrics also. Who knows? There is such a common condition. Okay. Now you see here, whenever you come across congenital torticollis, always looks for three association. Congenital torticollis is called wry neck. The affected side neck is tilted. The head is tilted towards the same side. Chin is towards the opposite side. This is how the baby will come to you. Whenever you see congenital torticollis or wry neck, you should rule out three associations: CTEV, CDH, metatarsus adductus. Metatarsus adductus. And you should rule out three syndromes: Down syndrome, Marque-Brailsford. Marque-Brailsford syndrome is nothing but it comes under mucopolysaccharidosis. Hurler-Hunter, the third syndrome is Marque-Brailsford. So it comes under mucopolysaccharidosis. Then Grisel syndrome. Cerebral palsy is not an association. Grisel syndrome, you know what is Grisel syndrome? Grisel syndrome, it's an ENT condition. When somebody suffers from severe URI or retropharyngeal abscess or severe viral infection, no, upper respiratory infection, what happens? there is unexpected sudden atlantoaxial subluxation. Sudden unexpected atlantoaxial subluxation, which will present like a torticollis. Okay, so whenever you come across this, don't forget Grisel syndrome, Marque-Brailford, Drowns. So far unasked in any of our Indian entrants, this may be a complete new question to you from ortho. Okay, we'll move on to the next question. Identify the X-ray and give you a diagnosis. Is it spina bifida? Is it sprungal deformity? Is it Klippel field? Is it cleidocranial dysostosis? Right answer is Klippel field syndrome. Klippel field syndrome. It is not spina bifida, it's not sprungal or cleido. Because when I see this is X-ray of lateral neck, lateral cervical spine. When I see, I am able to see all the cervical spine are fused to one unit. Okay, I am seeing C1, C2. After that, everything is fused together. So congenital fusion of cervical vertebra is called Klippel field syndrome. It's called Klippel field syndrome. Okay, you see here, X-ray shows fusion of the cervical vertebra. And one point I want to stress you, if they ask what is the investigation of choice, CT is there in the answer. CT is the investigation of choice. It is the investigation of choice, not the X-ray. CT is the investigation of choice. Okay, one should be very careful. And there is no definitive management. It is congenital fusion of cervical. The patient will have a short neck, a low hairline, and the patient cannot do this. The first vertebra is called atlas, second vertebra is called axis. Axis is axial movement. So the axial movement is not possible. Whenever you call, he will turn and see like this. That's all. But patient does not have any mental retardation. So except for this, no, and cosmetic reason, and this not able to turn his head, other things are normal. There is no definitive management. And one point I want to insist is, when you see this, no, all these vertebra are fused to one unit. Okay, this is bigger, in between, like a waist is narrowed, and this is called like a wasp. You see here, this is wasp, the hind portion, the front portion is like this, waist is very much narrowed, the wasp. Exactly, it looks like that, no? So this is called wasp waist sign. Wasp waist sign. So far unasked in any of our Indian entrants. This can be a futuristic MCQ in radiology and orthopedics. Wasp waist sign. The diagnosis is Klippel field syndrome. It's called Klippel field syndrome. We will move on to the next question. All of the following facts regarding Caffey's disease are true except, and I told you, no, Caffey's disease is otherwise called infantile hyperostosis. The right answer, treated with appropriate antibiotics, is the except answer. Okay, because infantile hyperostosis, otherwise called Caffey's disease, is self-limiting. It has no role with any germs or any organism. It does not need any antibiotic. Closest possible DD is osteomyelitis. Let us see in just 10 seconds infantile hyperostosis, otherwise called Caffey's disease. Rare idiopathic self-limiting disorder, common in children less than 6 months of age. It is characterized by rapid new bone formation in the infant. Most common site is mandible. Next common site is clavicle. It can happen in rib and scapula. This is a catchy point. Most common tubular bone is ulna. Most common tubular bone is ulna. Okay. Now, baby presents with fever, leukocytosis, and increased ESR. Severe tenderness of the affected bone and palpable swelling. Hyperostosis. Since the baby presents with fever and elevated leukocytosis, we will always suspect osteomyelitis. That is why it is the first DD is osteomyelitis. When you take an X-ray, since it is hyperostosis, you can see layers, multiple layers of periosteal new bone formation. Okay, you look at this X-ray, multiple layers of hyperostosis will be there, multiple layers of periosteal new bone formation. Okay, so since there is multiple layers of new bone formation, periosteal new bone formation, it will give an onion peel like appearance, so you may suspect Ewing sarcoma. So that is the second DD. Okay, since the patient is presenting with severe bone pain, scurvy is a DD, hypervitaminosis is a DD, and battered baby syndrome, no, it is child abuse. Battered baby syndrome, whenever fractures happen, healing happens by multiple layers of periosteal elevation may be there, periosteal reaction may be there, so that is considered as a DD. And coming to treatment, it is self-limiting. Maximum, practically I am telling, what we give is just paracetamol, pain relief, that's all. Paracetamol, admission, IV fluids, paracetamol. It will go by itself. It's self-limiting. That's no treatment is required. No antibiotics, nothing.